Welcome to the presentation on what I think is really underappreciated, but such an important part of more or less everything that we do in our clinical practice. My name's Nick Cates. I'm with the Department of Psychiatry and Behavioral Neurosciences at McMaster, so I'm a psychiatrist, but also have an appointment in our Department of Family Medicine. And I'm also very proud to be an honorary member of the College of Family Physicians. But I was told in no uncertain terms on the day I received my honorary membership that I shouldn't even begin to think about ever trying to practice family medicine. So I'd like to begin just with a disclosure. I have no financial or other supports. The only other thing I will add is I'm not an expert in sleep disorders. My knowledge, interest, understanding has really come from two areas. One has been through doing almost all of my clinical work in primary care over the last 35 years, and the other is as a person with lived experience who suffered from insomnia for many years, and who now packs their CPAP even before they pack their laptop before I go off to a conference. What I want to talk about, 5 areas. Why is sleep so important? The sleep cycle, what we mean when we talk about quality of sleep, how we assess insomnia, and how we treat insomnia. And I will be talking about medication right at the end, and the reason for that is mainly because it should be kind of the last step that we take in our treatment approaches. So what exactly is sleep? It's a dynamic and regulated set of behavioral and physiological states during which many processes that are vital to health and well-being take place. So it's a time when learning and memory consolidation occurs, when we balance ghrelin and leptin production, so it can also contribute to obesity. It helps regulate insulin mechanism, boosts the immune system, reduces cortisol levels, healthy brain development, protection against many chronic conditions. So it's an active and essential process. How much do we need? On average, and there's an enormous range, 7 to 9 hours, but anything less than 6 hours is not enough. And 45% of adults report not getting enough sleep, and 10 to 15% of us report chronic insomnia, almost half with daytime drowsiness. But 85% of teens probably don't get sufficient sleep. And there are 51 different genetic markers predicting sleep problems. So it's not only essential, it's really a complex process as well. Sleep needs vary over the life cycle. Newborns may sleep 14 to 17 hours at night. Older adults, 7 to 8 hours. But it's a myth that older adults actually need less sleep than younger adults. We all should be aiming for about the same. And if we don't get sufficient sleep, there are a number of very potentially significant health consequences. I won't go through everything on that list. Some of them I will come back to as we go through it. Interesting, there's some recent research looking at links between esophageal cancer and insomnia. And a study that just came out from the National Institute of Health in France last week looked at cardiovascular consequences of poor quality sleep. They saw 5 dimensions to poor quality sleep, which are listed there. Each of the 5 was given a rating out of 5. So the total for the best possible sleep, which was 8 hours a night for sleep duration, was 25. What they noticed at 2 years follow-up was that each point that you increased your score by reduced the likelihood of a cardiovascular event happening by 18%. And they estimated that over 30% of cardiovascular events could be prevented if we achieved a sleep score of greater than than 21. So again, just another example of the importance of sleep. And these are some of the cognitive impacts of sleep deprivation. Involuntary microsleeps, errors of omission, cognitive slowing, slower response times, learning, acquisition of cognitive tasks is reduced. And although tasks may be done well, our performance deteriorates the longer our period of sleeplessness or the greater our sleep deprivation increases. Physician performance is also compromised. 30% of us self-report chronic insomnia or another sleep problem, which is almost twice that of the general population. Not only is lack of sleep associated with burnout, increased psychological stress, and decreased job satisfaction, but you can see this one NIH study of surgeons found that after 18 hours or more without sleep, there were more medication errors, diagnostic errors, attention lapses, and injuries to yourself from needles. And when you have had less than 4 hours sleep, which is often the case for us, your functioning is impaired to the same extent as if you had a blood alcohol level of greater than 0.08%, which is the legal limit for not driving. Safety is also compromised. Half of us report driving while drowsy, and 17% of us have dozed off at the wheel with microsleeps. And in Canada in 2013, 10,000 sleep-related crashes, 150 fatalities. And if you look at the picture at the bottom, newer car models now have something that focuses on your eyelids, and as they start to close, it sets off an alarm. So this will soon become standard, I'm sure, in every new model. But it's also we're at risk at work for injuries and errors. And again, a quarter of us report being sleepy at work, and that's without the impact of hypnotic drug dependence. Also, 5 major disasters have been attributed to someone suffering from insufficient sleep in the chain of command. Chernobyl, 3 Mile Island, the Challenger explosion, the Bhopal industrial leak, and the Exxon Valdez. So, important consequences, but how do we sleep? And as you see from this, there are 5 stages of sleep. Stage 5 we refer to as rapid eye movement or REM sleep. Stage 1 and stage 2 are faster wave sleep. Stage 1, we're going to sleep, it's a transition, but different from microsleeps. And stage 2 is the time of memory restoration and moving memories around and muscle skill enhancement. Stage 3 and 4, which we usually put together, which is almost half of total sleep time, is where we store memories, we trim the synapses, we move memories around within the brain, and we also cleanse the brain. And you can see why this is such a significant potential contributant in sufficient stage 3 and 4 sleep to cognitive decline. Stage 5, REM sleep, is when we dream, about 25% of the total time. It originates within the prefrontal cortex. It's a time when we separate memories from emotion. So we may have experienced them during the day, but we store them in different ways. And it's REM sleep that contributes to cognitive functioning, emotional intelligence, memory integration, creativity, insight and problem solving. So it really does make sense to sleep on a problem and come back to it the next day, whether it's a work problem or even something like a crossword you're doing late at night. Come back to it the next day and it will seem different because you're thinking about it differently. Physical changes occur during REM. Infants spend a lot more time in REM. We spend progressively less time as we age. REM is suppressed by alcohol, by cannabis, and by antidepressants. So again, cannabis and alcohol at night are not necessarily a good idea. And there's some evidence that disrupted REM sleep in pregnancy may lead to autism spectrum disorder or ADHD. So typically more REM sleep earlier at night, more stage 3, stage 4 sleep earlier at night, more REM sleep later, which is why we may be more aware of dreaming as we get past 2, 3, 4 o'clock in the morning. For the older person, sleep becomes more fragmented, it's less deep, there's less REM sleep, which makes it slightly harder to store, integrate, and recall memories. Sleep efficiency is the time that you spend asleep divided by the total amount of time you spend in bed. So if you spend 6 hours asleep and you're in bed for 8 hours, your sleep efficiency is 75%, and we're usually aiming for at least 85%. 85% of your time in bed is spent asleep. It decreases in seniors. And we also know that the areas that drive deep sleep are also the areas in the frontal lobe that are most likely to show changes in Alzheimer's. So there may be a connection. It may also be that changes in non-REM sleep could be seen as a marker for dementia. And during stage 3 and 4 sleep, beta amyloid and other proteins are removed from the sleep, are removed during sleep by the glymphatic system. And the glymphatic system is really an interesting network of channels and canals which circulate throughout the brain. They include CSF, and they drain eventually into the lymphatic system. And interestingly, the nerve cells in the brain enlarge during the day, compressing these channels, and then they shrink at night, so the perivascular space expands. And it's at this time that the brain is kind of cleansed, neurotoxins are removed, and it may also be that this is how one of the ways the brain gets nourished, maybe again a part of the gut-brain axis, and reduced lymphatic activity is seen in all neurodegenerative conditions. It may be one reason why we need to sleep. And there are two processes that control our sleep cycle: sleep homeostasis. The pressure to sleep increases during the day. A chemical called adenosine drives our sleepiness. Caffeine reduces adenosine. Just out of interest, a 16-ounce Tim Hortons coffee contains 330 milligrams of caffeine. On average, we need between 400 and 600, two of those. And you can see why casinos have realized that if they can keep you awake, no clocks, bright light all the time, you move into the space where you start to make more of those cognitive areas I was referring to before. The second is our circadian rhythms, synchronized to the external environment. You come across people with potentially two circadian sleep disorders. One is advanced sleep, where they go to sleep too early and then wake early in the morning, and you can use light therapy at night. The second is delayed sleep phase disorder, and you can use light therapy in the morning as a way of treating that. And you can see again when melatonin is released. Melatonin drives the circadian cycle for sleep, and many teens naturally experience a shift to a later wake cycle. And that's because melatonin is released in less amounts, and it's released later in the night. And it obviously can conflict with their schedules. And a number of high schools now start their classes a little bit earlier. And if you're treating this, use melatonin, but try it 4 to 5 hours before a teen goes to bed, rather than just an hour before they want to try and go to sleep. Blue and white light make it harder to sleep. They suppress melatonin, which is why we say don't use devices in the hour or two before bedtime. No demonstrated benefit from blue light blocking glasses, and red light can aid sleep. Warm tones tend to relax us. So 2 cycles, they come together naturally about 8, 9 o'clock, and then as we get through to about 3, 4, they start to move apart. And you can see again melatonin being increased and then decreased. 2 common circadian disruptions, shift work and jet lag, both important. Shift workers have twice the likelihood of dying in a motor vehicle accident than non-shift workers, people on permanent shifts. And if you look at the theory of 1 hour to adjust for every hour of change in time, shift workers are working 8-hour shifts, 3 shifts, never have a chance to establish a normal sleep rhythm. Napping is encouraged, 20 minutes or less. This is NASA on the left, airlines. And one little tip, if you have a cup of coffee just before you nap, you'll fall asleep. It won't keep you awake then, but when you do wake up, you'll be more alert. So what affects the quality of our sleep? There are 4 things. The patterns of our sleep, how we sleep, our sleep habits, what we do immediately before and during our attempts to fall asleep, environmental factors, and when we look at what to do about those 3, those are what we talk about with sleep hygiene, and then other potential factors. We can measure sleep quality by the total amount of sleep we get, by nap times, sleep efficiency, and sleep latency. How long does it take us to actually get to sleep? And sleep latency can be both too long, but also too short. So you can have trouble getting to sleep, but sometimes if you find that you're falling asleep as soon as you lie down to have a nap, it's probably a sign that you're not getting enough sleep at night. This is just a simple trick. You ask someone to hold a spoon in their hand before they fall asleep and look at their watch. And when they fall asleep, the spoon will hit the tray that's beneath it, wake them. They'll look at their watch again and be able to tell you how long it took them to get to sleep. Sleep problems, although I'm going to focus on insomnia, there are really 6 groups. Insomnia, sleep-related breathing disorders, especially obstructive sleep apnea, sleep-related movement disorders, restless leg syndrome is just a feeling of tension in your legs when you're going to sleep. Periodic limb movement disorder are limbs flailing while you're asleep. You may not be aware of it, but your partner will be. Check iron, check folate, check renal function, and medications that can be helpful are gabapentin, pregabalin, clonazepam, and dopamine agonists. I usually start with clonazepam in small amounts. And ask about this in children who have ADHD. They may have restless leg. They may also have night terrors. And night terrors may be an indication that a child does have ADHD. The last group are the parasomnias. There are arousal, night terrors, sleepwalking, sleep talking. REM sleep behavior disorder is when you act out your dreams while you're asleep without being conscious of it, and a couple of others that can occur. Sleep apnea is a significant problem, 3 to 5% of adults. Risk factors are male, obese, over 50, and a family history. Those are some of the symptoms. If you see any of those, ask the individual more fully about sleep apnea, ask their partner whether they notice these same kinds of things as well. 2% of children will suffer from sleep apnea, and those are kids who snore. Sometimes it's because of enlarged tonsils, but usually it just resolves without you needing to do anything. The assessment is polysomnography. Greater than 30 is severe sleep apnea. You can't drive unless it's being treated. You have to report. And there may be an increase in white matter hyperintensities, which may contribute to some of the cognitive problems. Treatment options, behavioral approaches first, including losing weight. A sleep noodle, so that you're sleeping on your side rather than on your back. CPAP, continuous positive airway pressure, and BPAP is biphasic, which gives you higher pressure on the machine when you inhale and less when you exhale. And there are a couple of other things that can be considered. This is just something that is becoming, I think, more and more popular. And you will see, I think, more and more people who are either requesting it or have received it. Hypoglossal nerve stimulation. The generator is linked to the hypoglossal nerve. Breathing causes it to trigger an impulse, and this is implanted. The impulse causes the tongue to elevate and open the airway, and you can control the intensity through a remote control. People who have this say they prefer it to a CPAP. It's just easier and they can kind of forget about it. Insomnia is inadequate or poor quality sleep. It can be difficulty falling asleep, frequent awakenings, waking too early and being unable to get back to sleep, unrefreshed or non-restorative sleep, or daytime sleepiness or deficits in functioning, but distinguish it from fatigue. This is much more cognitive rather than more physical, which may suggest a different etiology. Insomnia can be primary, so that would be transient, which would last for a month, short term for 6 months or less, or longer term, and these are all factors that can contribute. But it can also be secondary to drugs, medical conditions, psychiatric disorders, or substance use. And when we're assessing insomnia, I think 5 steps, 5 areas to look at. The first is to suspect and ask. The second is to assess the quality of sleep, rule out a number of these conditions, track and measure sleep so you have some objective data, and then refer if needed. And looking at these in a little bit more detail, if you suspect, ask about whether someone is content with their sleep and whether they feel refreshed on awakening, which is likely to be insomnia. Are you excessively sleepy during the day, which may also suggest sleep apnea? And does your bed partner or parent complain about your sleep? So just some very simple questions to ask. And then assess the quality of sleep and sleep habits. How much sleep do you get and when? What are the patterns of your sleep? How long does it take to fall asleep? How many times do you wake during the night? How long do you sleep for? What do you do before and after going to bed? Do any environmental factors affect your sleep? And are there things you do during the day that might affect your sleep? Rule out a number of potential contributors, including psychosocial stressors. These are some of the medical conditions that can contribute to insomnia. And as you can see, there are a lot. Depression, anxiety, bipolar disorder, psychotic disorders, and substance use obviously all contribute as well. These are medications that can contribute to insomnia. I've included caffeine and chocolate in this list as well. They do sometimes have medicinal benefits. But again, you can see a wide variety that you need just to be aware of. In terms of measuring or tracking sleep, there are 3 or 4 things that you can do. This, and all of these handouts are in the attachment for this session. The Epworth Sleepiness Scale, 1 to 8, 8 items, each rated on 1 to 3, just asking a person to assess, do I fall asleep when I'm talking to someone, when I'm driving, when I'm watching TV, when I'm sitting in a chair. And that will give you, again, a fairly good idea of the severity of a problem. Polysomnography will usually require a referral, but sleep logs and diaries. This is a sleep tracker, and this you can give to a person and just ask them to mark how many hours they spent asleep. So not only is this helpful for you, but it may also be helpful for the number of patients who we see who really have no idea exactly how much they sleep, but think I've probably never slept more than 2 hours for the last 30 years. Not the case, but you need the evidence to confirm it. Sleep diary completed in the morning, and you just list what happened during your sleep each night. Keep it for a week and bring it back to you, and that will give you a good idea about patterns of sleep. And the sleep diary that you complete at the end of the day, or complete the next day, but this is about what you did during the day, just looks at sleep habits. What kinds of things are you doing that may be interfering with sleep? And you put those together and you have a fairly good idea of where you may want to intervene. And refer if help is needed with a diagnosis or management of a chronic sleep problem. Not every community has a sleep clinic, but they are becoming more and more common. In terms of treatment, and you see a lot of things I'm going to be talking about come in fives. 5 major areas: education, sleep hygiene, CBTI, non-prescription sleep aids, and prescription medications. In terms of sleep education, really important not only to talk about why we need sleep and why it's so important, maybe talk a little bit in very simple terms about the sleep cycle, dispel sleep myths, and some of them are just listed on the right-hand side. Alcohol before bedtime improves sleep, for example. But the other thing is to let them know there are alternatives to sleeping medication and that they really need to make sleep a priority. And I cannot stress how important that is. And it's really the concept of readiness for change. Until someone is in a position where they're saying, yes, this is something that I really need to do something about because it is affecting me in so many ways, they're still going to want to rely on easy fixes. And it is worth the extra time that you put in to try and get someone to the point where they say, yes, I really need to do something about this, rather than I need you to do something about this. This also in the handout, these are websites that provide lists of free sleep apps. So each one has a number of apps that you can recommend. Sleep hygiene, a number of, again, simple steps. A consistent sleep schedule, going to bed, waking at the same time every day. Keep napping to a minimum. A nightly routine that avoids things that may interfere with sleep. And this will be very individual. Some people will use a screen and have no problem sleeping. Some people may have coffee late at night and have no problems. Others may find if they have coffee after 4, it interferes with sleep. So tailor it individually, healthy daily habits, and a bedroom environment that's conducive to sleep. So again, set a consistent sleep schedule, including prioritized sleep. It's often the one thing that we sacrifice. We've got more to do than we can fit into a day, so I'll work an extra hour late, or I'll get up an hour earlier in the morning. It really is a kind of false economy. Keep naps to less than 20 minutes, restrict to early afternoon, and try really to avoid lengthy naps, because that reduces adenosine levels, and adenosine is what drives the homeostatic desire to sleep. Have a consistent nightly routine, including using relaxation techniques. And again, if you can't sleep, don't fight it. Don't stay in bed, tossing, turning, looking at your clock. Turn the clock around so you can't see it. Get up, do something that's relaxing, and then when you feel sleepy, as you will, maybe in 20, 30 minutes, go back to bed and then try and sleep again. You're trying to break a sort of conditioned habit. Bedtime routines, again, variation from individuals. Interesting that there's some recent evidence about scents, not just lavender or vanilla, a study that looked at 234 individuals who were exposed to scents last thing at night as opposed to a control group who weren't, and found that cognitive decline was lessened in the group who were exposed to scents. Read into it what you will, because there's not a lot of hard evidence for a lot of what I'm going to be talking about. But I think these are just things that you have at your disposal and your patient can try, and some will work better for some individuals, some for others. Journaling and dealing with your worries before bedtime. Again, a simple CBT for insomnia technique, but write things down that you can't get out of your mind. Make a list of things that you're worried about and turn the page before you go to bed. I'm going to leave it for tomorrow. Again, simple, but can be quite effective. Healthy daily habits during the day, and try not to eat large meals, caffeine later in the day, and restrict in-bed activities so that most of the time you're in bed, it's for sleep or it's for sex. It's not for other activities, particularly for someone who has insomnia. Optimize the bedroom environment, mattress, sleepwear, block out light. Some people find the weighted blankets can be very helpful. More used maybe in children, but can help get to sleep. CBT for insomnia. This is one study. There are many. This lower red line is CBTI, but the important thing is that the findings in this study, which show that the amount of time that it takes you to get to sleep are less than it is with combined treatment with temazepam than with a placebo, are not only maintained over a 24-month period, but are consistent in many, many different studies. CBTI is probably the treatment of choice for sleep problems and should be tried as the first step either on its own or in conjunction with medications. Again, groups of 5, but there are 5 different techniques: cognitive restructuring, stimulus control, sleep restriction, relaxation, and paradoxical intention. I'm going to mention a couple. Cognitive restructuring, simple CBT techniques. Identify thought processes that contribute to sleep anxiety, identify erroneous beliefs about sleep, challenge their veracity, substitute more appropriate thoughts. I'm never going to get to sleep. Well, no, you had a hard time sleeping last night or the night before, but how could you frame that into something a little bit more positive? Sleep is a challenge, but I know that if I do some of the changes that are within my control, I will be able eventually to get to sleep. So self-talk, distraction, alarm clock, and postpone worry episodes. I've got things on my mind, but I'll deal with them tomorrow, and journaling. Stimulus control is trying to break that conditioned or learned response to factors that interfere with natural sleep. And you're trying to break that cycle by promoting a consistent sleep-wake cycle, reassociating the bedroom with sleeping, so there are not other things that we do in bed to that may prevent us getting to sleep. And again, is a well-established standalone treatment. So go to bed only when you're sleepy. Don't spend time wide awake in the bedroom, and repeat, getting up, going back to bed as often as you need to, and don't nap during the day. So you're just trying to break a less helpful sleep cycle and replace it with one that is more relevant. Relaxation is helpful, always. These are, again, some routine relaxation techniques. But one that is very simple and easy to teach is 4-7-8. Based on yoga principles, you exhale through your mouth with a whooshing sound. So you exhale first, and then with the tip of your tongue against the top of your upper teeth. So you're inhaling through your nose. Breathe in for a count of 4, hold your breath for a count of 7, and exhale for a count of 8. And repeat 3 times. It's best to ask someone to try it first sitting up, but then just try that when they're in bed or when they're ready to go to bed, just to help to relax them and make it more likely that they're going to find it easier to fall asleep. In terms of non-prescription sleeping aids, a whole range of things that you can consider. These are a list of some. There are obviously many more that I could have put on this list. And again, I think if anybody comes to you and says, can I try this? I would support it 100%. Anything that works, and if it's something that the person feels is in their control, I am doing something about my problem, it's going to have even greater benefits. Some foods to consider before bedtime. Really want to mention 2 in particular. Tart cherry juice. These are Montmorency cherries. It does stimulate melatonin production, and there is some evidence, again weak, but it can be helpful. And again, this is something that someone can easily take and use to change their sleep. The second are kiwi fruits, which is interesting. And there is, again, mounting evidence that eating 2 small kiwi fruits before bed can both increase level of antioxidants, increase serotonin levels, and can help you get a better night's sleep. Some of the over-the-counter options that your patients may wish to consider, just with melatonin, remember that there may be variations in purity. So one form of 5 milligrams may not have the same benefit as another formulation of 5 milligrams. And prebiotics. I think there's more interest in the role of prebiotics in sleep. Prebiotics are the fibers on which the microbes in the gut live and multiply. So what you're doing is promoting microbe growth. And again, there's evidence that this can also contribute to better sleep onset and better sleep maintenance. These are just some of the foods that are high in prebiotics, but you can also get prebiotic capsules, or you can get prebiotic powders. So on to medication for insomnia. And again, the evidence for the long-term benefits and even the short-term benefits of medication is not strong. It is obviously a major issue in clinical practice, just working with the number of people who are either physiologically or psychologically dependent on something to help them sleep. And that's why if you do want to try and wean someone off a medication they've been on for a lengthy period of time, I think it's always helpful to be able to replace it with something else. And that something else is often some of those other techniques that I've been talking about earlier. This is from the American Academy of Sleep Medication recommendations in 2017. There are a variety of different groups to consider. We're probably more familiar with the benzodiazepine agonists, the so-called Z drugs, or benzodiazepines, and looking at using shorter acting and shorter lasting benzodiazepines. There are a variety of antidepressants that were never really that effective as antidepressants, but which work in slightly different ways and can help with sleep. One of the ones that's being used most frequently is doxepin, which is marketed for sleep under the name of Salinor, but it can be prescribed in 3 to 6 milligram dosages. If someone doesn't have drug coverage, you can still give a 10 milligram generic pill. And this works on histamine receptors. So although as an antidepressant it works on serotonin receptors, at low doses works on histamine and encourages sleep. Lemborexant is one of a group of orexin receptor agonists. So if you remember, adenosine increases sleep. Orexin is the substance that helps to keep us awake. And this is an increasing range of drugs. Lemborexant, I believe, is the only one available in Canada. If you are prescribing it, just make sure that your patient knows that there's the possibility of sleep paralysis when they first start the medication. It will only last for a few seconds. They'll be aware and awake but unable to move their body. If they don't know, it can be extremely scary. Doesn't happen very often, but it is a different side effect from some of the other medications. The other group, neuroleptics, obviously we try and use as little as possible and need to be very careful about contributing to arrhythmias. Prazosin is a drug that is used both for sleep but primarily for treating nightmares. And it can be very helpful in PTSD. Start with 1 milligram and gradually work up. You may go all the way to 7. And when I say gradually work up, go up by 1 milligram every 4 or 5 days. But if it's going to work, most people will find that it's helpful round about 4 or 5 milligrams and more helpful at 7 milligrams. If there's no response at 4 or 5, it's unlikely that it's going to work. And Ramelteon is a melatonin agonist, not yet available in Canada, but which will be probably arriving at some point in time. As I mentioned, low-dose cannabis does decrease sleep onset latency, but decreases REM sleep and also can suppress slow-wave sleep. Slow-wave sleep is the most restorative, so cannabis can reduce sleep quality. Again, not recommended just for sleep. These are the AASM 2017 guidelines. Choice for sleep onset insomnia, zolpidem, temazepam, zopiclone, lorazepam. Short-acting, the Z drugs or the benzodiazepines. For sleep maintenance, looking at doxepin, zopiclone, again, lemborexant, and maybe trazodone, again, one of the antidepressants that's kind of crossed over. For seniors, group on the left, doxepin, zolpidem, trazodone, or just melatonin, and temazepam or lorazepam are also options. And a number of drugs can be helpful when either pain is contributing to sleep or pain and sleep and insomnia going together, and one affects the other. So the less you're sleeping, the more aware you are of your pain, the better your pain, the more likely you are to sleep. And they include gabapentin, duloxetine, topiramate, and pregabalin. When using medication, manage the relationship. Don't feel pressured into just doing something. Education and have a clear contract around duration and why you're prescribing it for a shorter period of time. Sleep hygiene and CBTI first or in combination. Use the minimum effective dose and watch for psychological as well as physiological dependency, particularly when people come back and they're asking you for an increase in their dose. Review potential side effects and also ask them to keep an eye out for daytime sleepiness. Just be aware of any potential drug interactions, contraindications. Look for rebound insomnia after discontinuation. And it can take, for someone who's been on benzodiazepine for many years, it can take up to 6 months for kind of the sleep cycle and sleep architecture to return to kind of their pre-medication state. Consider intermittent use if long-term therapy is required, and maybe sometimes a consultation with a sleep specialist who can reinforce the messages that you want to provide. Avoid prolonged or excessive therapy, always discuss the risks and benefits, and agree on the plan beforehand rather than introducing it halfway through. Sorry, you've been on it 2 months, that's as long as we want to go. So someone is prepared and can adjust the way they think about medication accordingly. Keep continuous therapy as brief as possible, and look at periodic tapering and discontinuation trials to determine whether it can be stopped before you actually stop it. As needed therapy, 6 months ideally for a benzodiazepine, longer for others, and this is more helpful for patients who can actually assess whether they are responding to the medication or not. This is a single handout. It's things that you can do to help you sleep. It's 11 tips that I've gone over, mostly in sleep hygiene and some of the simple CBTI techniques. But, print this off, give a copy to your patient to take away, and just suggest they choose whichever one makes the most sense. There are lots of things they can choose, but again, if they're choosing, it's much more likely to be effective than if it's you who's suggesting which one they should choose. And really, in summary, sleep is an active process. It's not just a time when we're not awake. It's important for physical and emotional well-being. It's part, and it should be part, of the integrated treatment of all health problems. So anytime you're seeing someone with any health condition, ask about sleep. It may not be your primary focus, but it may be something that you want to incorporate into the management plan. It needs to be seen as a priority, not the first thing to sacrifice. It can be very difficult to treat. It's not easy. I don't need to be telling you how difficult it can be, not only to treat, but to help to get people off medications they may have been on for many years. So sleep hygiene, CBTI, keep drug therapy brief, and if you take away one message from this session, it would be this: really look after your own sleep. As I say, sacrificing sleep is a false economy. In the handout, if you want to contact me about anything that I've talked about, that's my email address. In the handout, you'll find some online self-help resources, the websites I mentioned. This is one, I found it the most interesting and readable book about sleep by someone called Matthew Walker. And these are the scales I mentioned earlier. And this is the printout of things you can do to help you sleep. Thank you. So, I have to remind you to fill out your session evaluation forms now, ! And are there any questions?
Hi there. I'm curious about if you're on your phone, Apple often has something where you would dim the light to more of a red light or something like that. I'd be curious, how effective is that, or is that pretty much just doesn't work at all, and just really, you know, it's still better to discard the phone, even if you're just using it for reading, or even if you're using an iPad or something like that?
Yeah, I would say for all of those things, every little bit counts. But the other important thing, it just comes back to the message about if someone feels they're taking charge of their problem, there's something I can do that's going to help me sleep, it's more likely that the power of suggestion will actually help them sleep.
Thanks.
Yeah.
Hi, thank you so much, Dr. Gates, for the talk. I'm sure we've all had those patients where, you know, may have inherited them on long-term benzo sort of thing. It's the only thing that helps them. You've maybe talked to them about the idea behind CBTI and stuff like that, and maybe there's not too much buy-in. Like in one of those sort of types of patients, usually, like, what's your conversation, what's your approach to try to, at the very least, you know, try to get them to maybe try CBTI, or, you know, maybe even help them consider coming off the benzos or something like that?
I think the first thing is always to take the long-term view. So you're not thinking about a quick fix. It may be a year before they're ready to decrease or start to discontinue. I think the second thing is I'd just be talking about looking at reducing the dose rather than stopping it. And that's where I think education comes in, just explaining why I'm suggesting that. What are some of the drawbacks from being on the medication? And maybe there's some other things that you can try that may be as helpful or even more helpful than the medication. And then I think it's a question of readiness for change. So I would work with them, introduce some of those things on a gradual basis, so that they reach the point where maybe they do say, yes, there are either other things I can try, or that these things have helped a little bit, or now I am ready to begin to look at how I reduce it. But there will be some people, you know, who certainly I've tried, and in the end, I just haven't been able to reduce it. And, you know, having explained all the risks and trying to keep the medication to a minimum, I have continued the prescription.
Thank you.
I have a question.
Yeah.
As a resident medical doctor, I try to give non-pharmacological advice, but I get they give the feedback to my preceptor saying that this doctor does not want to give us medication, or if I try to de-prescribe, they say, I have been using this medication for quite a few years. This doctor tells me to stop this medication. So I'm at the mercy of them, basically. So it's very difficult for me to make that contact. So I try to give them advice, something like CBT, but I use the meditative technique where I tell them, do not suppress the thoughts, do not create new thoughts, or do not listen to sounds or other thoughts and pursue them as a way of calming them down. Just like the muddy waters, you just observe, being a witness, and they'll settle down after some time. But in your slide in the CBT, I was confused. Did you say that you can use counter thoughts to suppress these thoughts, or do you mean do not counter those thoughts?
Yeah, well, firstly, I think, you know, the kind of approaches that you're using, anything is helpful, and you find certain things work better with certain people. With the cognitive therapy approach, what you're trying to do is take the maladaptive thought that may be interfering with their ability to fall asleep. So that's different from a relaxation technique. You know, what they worry about with their sleep or not being able to sleep, and replace it with a thought that's more adaptive.
Okay, thank you.
Yes, thank you. Is there a problem if you take melatonin over a long period of time?
There's no evidence that it is. There's probably a little bit of likelihood that it will lose a little bit of its effectiveness. But I think generally I would advise people not to take it on an everyday basis, but to take it intermittently or periodically. And again, to do it when they begin, so that when they start this medication, however helpful it is, they already have in their mind the idea that this is something that can help me in the short term many times, but not necessarily I'm going to rely on to get to sleep every night.
And if that person doesn't have problem falling asleep, yes, problem staying asleep, would melatonin do something?
Yeah, it can. And again, it can be 3 or 4 hours before the oral melatonin reaches its maximum impact in the body. So taking it at 11 can still help people who wake at 2, 3 o'clock in the morning.
Thank you.
Thank you. I was wanting to ask about shift work, people needing to use any kind of medication, like kind of sometimes 1 to 2 times a week. Is this an okay thing to do long term, assuming that it's a situational issue? They're wanting to switch from nights to days, vice versa. And what's the cognitive impact of that?
In terms of just switching the times at which they take the medication?
Yeah, and
Yeah.
the requirement is very specific.
Yeah, it's a good question. There's not a good answer. I try and suggest that people take their medications in conjunction with what they're doing at that point in time. So their morning meds are when they wake, their evening meds are when they are getting ready to go to bed or go to sleep. If there are specific medications that need to be taken at the same time, 24 hours apart, then they'll just have to make some adjustments to do that. But usually it's easier and compliance is better if they just take it at their natural time, and they also get into the natural rhythm of taking their meds at those times, rather than suddenly saying, oh, it's 4 o'clock, I forgot my 8 o'clock meds.
I understand, sorry. And just to clarify, I meant sleep-inducing medications. So someone needing to use like Zopiclone to be able to sleep
Yeah.
during the day, all that too.
Yeah, again, at their natural waking, at their natural bedtime, maybe a little bit earlier, but I think they'll work out over a period of time what's the best time for them to take those medications. So I would suggest they take it at their bedtime, but just also ask them, did it help if you took it 2 hours earlier than usual, or did it help 2 hours later? Shift work is horrible in terms of sleep, and there are always going to be challenges, exactly like the ones that you're talking about. So I think it's individual trial and error.
Okay, thank you.
Thank you. I hope we have time for another question. I wanted to ask about insomnia and menopause, and it being a common symptom. Any suggestions on non-pharmacologic versus pharmacologic effectiveness in approaching insomnia during perimenopause and menopause?
Yeah, I think it's important just to separate out, are these perimenopausal symptoms, or is this either a pre-existing or an unrelated sleep issue? And if it's the latter, then there may be other approaches that you want to take. Excuse me. In terms of specific specific approaches that may be helpful, I think it's really any of the above. I think the lifestyle ones, exercise, alcohol, diet, are probably near the top of the list. Night environment, bedtime environment, sleep hygiene, I think would also be things to consider. But there really isn't anything that is specific for
So nothing unique in that
No.
context. Thank you.
I'll be quick. I'm just curious if you have any insights on the accuracy of wearable devices like Apple Watches and Garmin about the amount of sleep, but also the phases. Like I know my watch tells me I got this much REM, this much deep, and I feel like it's probably garbage, but I don't know.
Yeah, there is some accuracy in those things. I would tend to use them more as a guide rather than sort of empirical evidence, and use one or two other of the instruments that I mentioned before just to try and get a fuller picture of what the sleep patterns are. But yeah, there are more and more people who are more and more reliant on their actigraphs, and I think you have to go with it rather than challenge it.
Just a quick question here on CBTI for sleep. Do you have any like practical tips for implementing it in your practice? Like how often do you see people back and keep working through those techniques with them?
Yeah, usually it's, well, some of the techniques are ones that you can teach in one or two sessions, like relaxation, or some of the ones about changing sleep habits. For more formal CBTI, most of the programs or treatments are between 12 and 16 weeks. In primary care, I think it can definitely be abridged, and that you can pick on 3 or 4 of the key things that you want to work on and do them in 5 or 6 weeks, whether that be 6 weekly or every couple of weeks. But the important thing is for the person to be given homework and to be working on that homework in between sessions. So they're practicing, they're not just relying on coming to see you. Things like journaling, things to worry, postponement, those are things that you can do in a single session. But follow up just to reinforce it and see what's working, what isn't working.
Hi, I'm a bit confused about one of your first slides that says that we need minimum 6 hours of sleep. How do you manage your older patients, like 70, 80 years old, who sleep maybe 4 hours per night, and they say they have insomnia, but they're not tired during the day? How do you manage that?
Yeah, I think there's great variation. So we say the range of needed sleep is 7 to 9 hours. If you're getting less than 6 hours, then you're in that area where you're likely to experience problems or potential health consequences. For people who are sleeping less than that, irrespective of what their age is, but as you say, it can be more of a problem in older patients because sleep does become more fragmented. I would get as good a sleep history as possible to find out what actually is happening. Are there things that are keeping them awake? Are there things that they're doing before they go to sleep that may be contributing to this problem? Are there reasons why they need to get up early in the morning? I mean, one thing that we tend not to ask about is people often have less sleep because they have a pet that needs to be taken care of at 6 o'clock in the morning and they can't get back to sleep after that. So look at all of those kinds of factors and just see if there's anything that you can do to introduce changes. But other than that, I think it just then does require education first and foremost, and then some of the sleep hygiene techniques that I was talking about earlier.
Okay, but I'm still confused about if they don't sleep more at least 6 hours, but they're not tired. Do you see this as a medical issue? No?
No.
Okay, thanks.
No, and not just not being tired, but as long as they feel they can keep it with what they need to do and they're not showing any signs of, any kind of cognitive impairment on tasks they need to do. No, that's fine. That would be individual variation. I would point out that both Ronald Reagan and Margaret Thatcher boasted about never needing more than 5 hours sleep at night, and both of them ended up with dementia for the last 10 years of their life.
Hi there. Just quick question. Do you have any class of medication or particular medication that is more effective than others that you prefer to use?
I would tend, and again, some of this depends on what coverage is available to my patient. But I think that I would be looking to begin with at Doxepin, Lemborexant, and then one of the shorter acting benzodiazepines or one of the Z group of drugs, and probably a Z drug before a benzodiazepine.
Can you combine all the medication together?
Yeah, it's never a great idea with sleeping medications because it means that the one medication to which you're adding something is probably not working. So I would try and avoid it. The only thing sometimes can be adding melatonin or an over-the-counter. But again, I think rule of thumb is try and stick to one. Great. Thank you very much.